So now let's see the next topic being delta ratio. So till now we dealt with the 4 steps. Next, if it comes out to be high anion gap metabolic acidosis in the step 4, high anion gap metabolic acidosis, then we proceed on to calculating delta ratio, step 5. So let's understand the concept of delta ratio. Normally what happens is for every pathologic acid that is added, pathologic acid is nothing but anion. It loses its H plus and becomes anion. One HCO3 minus should be removed. Correct, no? Pathologic acid along with one H plus gets dissociated. H plus combines with HCO3 minus. Okay, this is the buffer action of HCO3 minus. So for every pathologic acid added, H plus combines with HCO3 minus. Correct, no? So one HCO3 minus has to be removed. So this maintains the acid base balance. Acid base balance is hence maintained. This is what happens normally. So we can tell that change in the anion gap approximately equals change in HCO3 minus, because change in anion gap is nothing but the amount of pathologic acid that is added. Pathologic acid that is added causes change in the anion gap, and HCO3 minus keeps getting removed. So change in HCO3 minus will be approximately equal to 1. That is what we can claim. This is nothing but delta ratio. Delta ratio is nothing but change in anion gap divided by change in the HCO3 minus. So this being the formula, it might be slightly greater than 1, because just not HCO3 minus act as buffers. We have seen that there are many other extracellular buffers as well. So it might be slightly greater than 1 as well. So for different pathologies, for different causes of high anion gap metabolic acidosis, we can expect different delta ratios. Like for lactic acidosis, clinically calculated values, these are 1.6, ketoacidosis 1.0, and for toxic alcohol poisoning it can be around 1 to 2. So these are the expected values. Now next we'll see what is the importance of delta ratio is. If it doesn't fall in this range, that means there is some underlying process, some secondary underlying process other than high anion gap metabolic acidosis that is not letting the body to compensate, that is not letting the system to compensate, or that is not letting the HCO3 minus buffer to equally balance out the pathologic acid that is being added. So there is some other secondary underlying process. So let's see what happens. This is what we saw normally. What happens once pathologic acids get added, in case of high anion gap metabolic acidosis, change in the anion gap. Let's say anion gap normally is 12. So the change in anion gap being 20, change in anion gap and change in HCO3 minus. Over here what happens, change in anion gap will be, anion gap is 24, change will be 12. What is the change in HCO3 minus? HCO3 minus is again 12, 24 minus 12, so it will be approximately equal to 1. This is what we expect to happen, but there might be certain conditions. See over here, pathologic acid is being added, but the concentration of HCO3 minus is high. That means what could have occurred? We would have ideally expected it to be 12. For this amount of pathologic acid added, ideally expected it to be 12, but HCO3 minus is high. That means metabolic alkalosis is there. There is secondary underlying metabolic alkalosis which has caused this HCO3 to be high. So what happens over here? Change in anion gap remains the same, 12, but change in the HCO3 minus is only 6, 24 minus 6. So this is 2. It is higher than the expected value. So whenever delta ratio is higher than the expected value, then we can conclude that there is secondary metabolic alkalosis as well, because HCO3 minus values are greater than what can be expected. Next scenario, let's see. Again, there are pathologic acids that are being added, indicating high anion gap metabolic acidosis is there, but HCO3 minus over here is very much low. It has not only even after combining with pathologic acids, we would have expected it to be around 12, but it is very much low. It is around 6. So what has happened over here? What could be the cause of such low HCO3 minus over here? That indicates that there is another secondary underlying process. So whenever there is lower than the expected value, we can tell that there is one more metabolic acidosis present. Since HCO3 minus loss is the cause, we can tell that normal anion gap metabolic acidosis as well is present in this condition. Okay, so these are the two scenarios. When it is lower than the expected range, we can tell there is normal anion gap metabolic acidosis. This was the clinical scenario. When it is in the normal range, then we can tell it is AGMA being the only process. When it is in the higher range, then we can tell there is AGMA as well as metabolic alkalosis. This was the clinical scenario. Okay, we'll go to next problem. We'll go to the next problem. Okay. So can we solve this sum? Can we solve this sum? Example number 12. Quick. Example number 12. High anion gap metabolic acidosis along with metabolic alkalosis. Excellent, Melvin. Excellent. Very good. So we'll solve this. We will solve this sum. See, initially pH is reduced. pH is reduced. So there is acidemia in the body. PCO2 as well as is reduced. So we can tell it is metabolic acidosis. Next step is to calculate for compensation. This was step 3. For every 1 milliequivalent reduction in HCO3 minus levels, 1.25 should be reduced. PCO2 should reduce by 1.25. HCO3 minus has reduced by 12. So this will be equal to, not 12, 10. This will be equal to 12.5. So we would have expected PCO2 to decrease by 12.5. So compensation is adequate. It has decreased by 12. So adequate compensation is found. Adequate compensation is there. Next we should calculate in case of metabolic acidosis. We should see anion gap. We should see anion gap. What is anion gap? 138 minus 84 plus 14. So this will be around 84 plus 14. 38 means it will be around 30. Around 30 milliequivalents per liter. It will be around. So this has increased. High anion gap metabolic acidosis. High anion gap metabolic acidosis is there. High anion gap metabolic acidosis. So next step was to calculate delta ratio. Delta ratio is change in the anion gap. 30 minus 12, it will be 18. Divided by change in HCO3 minus levels. 24 minus 14, it will be 10. This way, this will be 1.8. 1.8. This is surely high. This is surely very much high. Very much high. So when it is higher, we saw that there is secondary metabolic alkalosis as well. So there is AGMA plus metabolic alkalosis. Yes. So Shravanti and Melvin got it right. Very good. So the last step is to see the history. See the history and correlate. And correlate. What was a 24-year-old person comes to casualty consuming poison and multiple bouts of vomiting. Okay. Since there is vomiting, HCl goes out. That will contribute to metabolic alkalosis. Then he has consumed some poison. He's consumed some poison, which has led to high anion gap metabolic acidosis. Poison is the cause for AGMA. Vomiting is the cause for metabolic alkalosis. So let's solve the next sum. Next sum. Which one can we solve? This one. Example 14. If you guys can solve. Answer for this question. Anyone can solve this question. First step is to see the pH. There is alkalemia. Now we see the PCO2. It is reduced. So there is respiratory alkalosis. Respiratory alkalosis. Correct now? Next we check for compensation. Next we check for compensation. So for every 10 mm Hg decrease in PCO2, HCO3 minus should decrease by 4. HCO3 minus should decrease by 2. Since over here it is decreased by 20 milliequivalents. HCO3 should decrease by 4. So, but it is much lower. Since it is much lower than the HCO3 minus should have been 20. Since it is much lower than the expected value, there is metabolic acidosis. Next, since there is metabolic acidosis, we see the anion gap. Okay. What is the anion gap? 127 minus 79 plus 17. So this will be somewhere around 31. It is surely increased. So there is high anion gap metabolic acidosis. Whenever there is high anion gap metabolic acidosis, we further go ahead and calculate delta ratio. Change in delta ratio is 31 minus 12. 31 minus 12 will be somewhere around 12, 22, 90. 90 divided by change in HCO3 minus levels. HCO3 minus level has changed by 20, that's changed by 7. Correct, no? So if we do this, there will be 7 2s are 14, 2.5 something. This is surely high. This is very much high. If the problem is, if delta ratio is very much higher than the expected level, then we tell that there is metabolic alkalosis as well. So we see three disorders over here. There is respiratory alkalosis plus high anion gap metabolic acidosis, plus we have metabolic alkalosis as well. Next, we go back and relate to history. We correlate with history. What does history tell? A 70-year-old gentleman, he was admitted for congestive cardiac failure. Congestive cardiac failure means the patient is almost in shock. If he is almost in shock, there will be increase in lactate levels. If there is increase in lactate levels, there will be high anion gap metabolic acidosis. So do we have high anion gap metabolic acidosis? Yes, we have high anion gap metabolic acidosis. Then we further proceed. He has been vomiting since 2 days. Since he's been vomiting, if he vomits out HCl, from the stomach, there will be metabolic alkalosis. Acid is lost, so we'll have metabolic alkalosis. So the second picture is metabolic alkalosis. He has also been having severe abdominal pain. If there is severe abdominal pain, if there is anywhere pain in the body, then the patient will start hyperventilating. If there is hyperventilating, there will be increase in the respiratory rate. If increase in respiratory rate will be there, patient will have respiratory alkalosis. So you have respiratory alkalosis. So this is a very dreaded combination. There is a triple disorder. It is very, very difficult to treat. Patient is in shock, he has vomiting, he has respiratory alkalosis as well. So there is 3 deformities over here, 3 disorders present over here: respiratory alkalosis, high anion gap metabolic acidosis, and metabolic alkalosis. So just by using ABG, we could see 3 underlying disorders and its etiology. Correct, no? This is how beautiful ABG is. So now what was the doubt? What's the margin we considered? Margin we considered was done in the table. See, if there is lactic acidosis, it should be around 1.6. If it is ketoacidosis, it should be around 1. If it is due to some toxic alcohol poisoning, it should be around 1 to 2. This is the margin to be considered. This covers almost, this accounts for 3 major etiologies of high anion gap metabolic acidosis. This is the margin to be considered. If not, also 1 to 1.5 can be considered as normal. Okay, 1 to 1.5. This
With this, you can usually solve all the clinical problems, not just theory. Even in ICU setup, with this, we can solve all the clinical problems. Hope you guys understood. Hope you guys understood this. Now let's come to the last problem for the day. Example 15. With this, we'll wind up. It's been more than an hour, so we'll solve this one problem and wind up.
So now let's solve this sum. Example number 15. Example number 15. A 61-year-old morbidly obese came with complaints of COPD and congestive heart failure. These are the acid-base parameters and serum electrolytes. Over here we see something atypical. pH is almost normal. pH is almost normal, but the PCO2 and HCO3 minus levels are deranged. So this was one scenario to indicate that even with absolutely normal pH values, there can be acid-base disorders. Why? Because there can be two disorders. Like for example, there can be a metabolic acidosis with respiratory alkalosis, this causing decrease in pH, this causing increase in pH, and both cancelling out each other, causing the pH to be normal. This makes the pH to be normal. Okay, but despite pH being normal, if we move ahead and check at PCO2 and HCO3 minus, they will be deranged. So this was one such clinical scenario, just to show you guys that even despite the pH being normal, there can be acid-base disorders. So let's solve this problem. We cannot comment on acidemia or alkalemia looking at pH. Then let's proceed and look at PCO2. PCO2 is high, indicating there is respiratory acidosis. Next, we look for compensation. When we look for compensation, we see that HCO3 minus are very much higher than the expected value. When does this happen? This happens when there is secondary metabolic alkalosis. And anion gap on calculating was normal, around 7 to 8 it was. So anion gap was normal. Anion gap is normal. So we can tell that there is respiratory acidosis along with metabolic alkalosis. Both these things together tends to make the pH normal. These are other such scenarios. No need to do in detail, just to give you guys the example. Like one more example can be this. PCO2 is high, HCO3 minus is high, anion gap as well is high. When does this happen? PCO2 is high, so respiratory acidosis. HCO3 minus is high, so metabolic alkalosis. And when will anion gap be high? When we expect high anion gap metabolic acidosis. So what is happening over here? There is respiratory acidosis and high anion gap metabolic acidosis, which is decreasing the pH, and there is metabolic alkalosis, which is increasing the pH. These two cancel out each other and tends to make the pH normal. Okay, so now till now we have read many such situations where there can be two acid-base disorders, or scenarios where there can be three as well, where there can be three scenarios as well in one patient itself can have more than one scenario. So we'll see how. We'll list out now all the scenarios possible for this to occur when serum bicarbonate and PCO2 go in opposite direction. Here they mean to say, like, let's take pH is reduced and HCO3 minus is also reduced. So we expect a metabolic acidosis. Now in as a result of this, body compensates by decreasing PCO2. Body compensates by decreasing PCO2. Correct now. But if we see that PCO2 is high, if we tell that PCO2 is high, these two are moving in opposite directions. So there is one more disorder. Now this means to say that there is one more disorder causing respiratory acidosis, not letting the body to compensate, which is the reason for high PCO2. So again a mixed picture. Then there is disparity in the degree of change. This we saw in many scenarios wherein when it was not adequately compensated, we used to tell that there is some other disorder which is not letting the body to compensate adequately. Correct, no? So this disparity in the degree of change means that when there is high anion gap despite fairly normal acid base parameters, even then we can think of mixed picture. Or everything appears near normal but the clinical scenario of the patient doesn't say so, then we can think of some mixed picture. So now let's come to the summary of what we have done today. So we dealt with ABG analysis using the traditional approach, 6-step approach. In this 6-step approach, Henderson-Hasselbalch equation was the central. Henderson-Hasselbalch equation with HCO3 minus being the central towards our learning the traditional approach, in which we saw that pH, HCO3 minus and PCO2 are dependent variables, in which if there is change in one, there will be change in other as well to make the pH normal. So change in the pH causes the 4 basic acid-base disorders and the body tries to compensate it. To know which acid-base disorder is there, we do ABG analysis. Following the procedure, we check for accuracy by calculating the HCO3 minus and comparing it with the one measured using serum electrolytes. Next step is to see the pH and see whether the patient is in acidemia or alkalemia. Once this is confirmed, we will see whether the process is metabolic or respiratory by checking PCO2. If they move in the same direction, it is metabolic. If they move in the opposite direction, it is respiratory. Then coming to the compensation, using the formulas given in the table, we can tell whether it is a simple acid-base disorder, which means it is compensated. If not, it is a mixed acid-base disorder. Then we will come to step 4, wherein we see anion gap. If it is high, we can tell there is high anion gap metabolic acidosis. If it is normal, then nagma, these two being the types of metabolic acidosis. If there is hagma, then we see calculate delta ratio. If it is not within the normal limits, again we can think of a mixed picture. Last step is we correlate clinically, try to find out etiology. This last step will be dealt in tomorrow's class. The 4 basic acid-base disorders and the causes for it will be dealt in tomorrow's class. So this was an approach, a systemic way of approaching acid-base analysis. Hope this class has helped you guys. So we'll wind up. Thank you.